Hyperosmolar Hyperglycemic State by Nicholas Jeanette,
Crystalline Beltran,
and Marcella Bawag.
By the end of the presentation, the student nurses will know the definition of hyperosmolar hyperglycemic state, the pathophysiology of hyperosmolar hyperglycemic state, or HHS, the causes of HHS, the signs and symptoms of HHS, the risk factors of HHS, the diagnostics of HHS, treatments of HHS, and discharge teaching and prevention of HHS.
Okay, so HHS is a hyperosmolar state that's caused by hyperglycemia, with hyperosmolar meaning elevated blood osmolarity. And it's different from diabetic ketoacidosis or DKA in that ketone levels in HHS are absent or low, and the blood glucose levels in HHS are also much higher, with the blood glucose levels being greater than 600 or the blood osmolarity being greater than 320. And it's a life-threatening emergency that's manifested by an elevation of blood glucose and hyperosmolarity with little to no ketosis. That's the definition of it. So the development of HHS instead of DKA is related to residual insulin secretion, where in HHS the patient secretes enough insulin to prevent ketosis, but not enough to prevent hyperglycemia. In HHS, the hyperglycemia is more severe with an increasing blood osmolarity that leads to extreme diuresis with severe dehydration and electrolyte loss. Low blood volume, which is caused by osmotic diuresis or underlying kidney disease, can lead to further kidney function deterioration. And the reduced kidney perfusion from the hypovolemia further impairs kidney function. So low volume leads to reduced GFR, which leads to a rise in glucose level. And the kidney impairment seen will allow for significantly high glucose levels because the kidney's capacity to reabsorb glucose is surpassed as the concentration of glucose surpass the renal threshold.
Both HHS and DKA are caused by hyperglycemia and dehydration. HHS results from a sustained osmotic diuresis, and it's also caused by infection, sepsis, pancreatitis, myocardial infarction, stroke, some medications such as glucocorticoids, diuretics, phenytoin, beta blockers and calcium channel blockers, substance abuse, undiagnosed diabetes, and non-adherence to therapy. Signs and symptoms of HHS include a central nervous system change, ranging from confusion to complete coma. The patient may have seizures and reversible paralysis, unlike diabetic ketoacidosis, and the degree of neurological impairment is related to serum osmolarity, with coma occurring once serum osmolarity is greater than 350 milliosmoles a liter. Blood sugar level greater than 600 milligrams a deciliter is another sign and symptom. Drowsiness and hallucinations, increased urination, excessive thirst, dry mouth, fever, vision loss, profound dehydration with poor skin turgor, and a rapid and thready pulse are also signs and symptoms of HHS.
So the signs and symptoms that differentiate DKA and HHS is that DKA is sudden, whereas HHS is more gradual. The precipitating factors for DKA are mostly related to an inadequate insulin dose, whereas in HHS it's mostly through poor fluid intake. And the manifestations of DKA include ketosis and Kussmaul's respirations, which is like a rotting fruit breath, is also included. And for HHS, manifestations include altered CNS functions with neurologic symptoms.
Risk factors. Risk factors of HHS result from sustained osmotic diuresis. Kidney impairment in HHS allows for extremely high glucose levels because blood concentrations of glucose exceed the kidney's ability to reabsorb glucose. Osmotic diuresis or kidney disease result in decreased volume, especially in the older population. This condition can further exacerbate any kidney damage. HHS typically occurs in people with diabetes type 2, especially in the older population. Mortality rates are 40 to 70% in older population, decreased thirst center, poor urine concentrating abilities, and the use of diuretics all lead to dehydration, which can cause HHS and type 2 diabetes. Also, MI, sepsis, pancreatitis, stroke, and some meds also cause HHS. Development of HHS versus DKA is dependent on residual insulin secretion, preventing just enough to prevent ketosis. Diagnostic tests performed include serum glucose greater than 600, osmolarity greater than 320, serum ketones negative, serum pH greater than 7.4, serum HCO3 greater than 20, serum sodium normal or low, BUN elevated, creatinine elevated, and urine ketones negative. These are all diagnostics found in HHS. Treatments. So the goal of treating HHS is to rehydrate the patient and restore normal glucose levels within 36 to 72 hours. Choice of fluids is very important and critical in managing HHS. Level of CNS effect of HHS is dependent on level of blood hyperosmolarity. Reestablishing fluid balance in the brain cells is difficult and a slow process. Many patients do not recover baseline CNS function until hours after blood glucose levels have returned. The first priority is always to replace volume using 0.45% NS. CVP monitoring needed for CHF and CKD or acute injury. Always assess for signs and symptoms of cerebral edema. IV insulin is administered after adequate fluids have been replaced. Glucose reduction of 50 to 70 is an expected outcome. Replace potassium when urine output returns back to normal or is greater than 30. Check serum electrolytes every 1 to 2 hours until stable, and always monitor cardiac rhythm.
Discharge teaching and prevention. On discharge, the patient should be taught to seek care immediately if they are urinating more than usual, if they are thirstier than usual, or if they are more drowsy than usual. They should be taught to contact their healthcare provider if their blood sugar levels are higher than their healthcare provider says they should be, if they had blurred vision, if they have a fever, or if they have any questions or concerns about the condition or care. In terms of medications, insulin may be needed if you have type 2 diabetes that cannot be controlled with diet, exercise, or other diabetes medicine. They may need 1 or more doses of insulin each day. They should be taught to take their medicine as directed, and to contact their healthcare provider if they think their medication is not helping or if they have side effects. They should be taught that if they are allergic to any medicine, they should also keep a list of the medicines, vitamins, and herbs that they take. They should include the amounts and when and why they take them. They should also bring the lists or the pill bottles to follow-up visits. And they should also carry their medication list with them in case of an emergency. In order to prevent HHS, they should check their blood sugar levels regularly, they should take their insulin or diabetes medicine as directed, and they should also prepare for sick days.
NCLEX style question number 1 is, which of the following are indicators of hyperosmolar hyperglycemic state? Select all that apply. A. Blood glucose levels greater than 600. B. Blood osmolarity greater than 320. C. Positive ketones in blood. D. Negative ketones in urine. So the answer is A. Blood glucose levels greater than 600, B. Blood osmolarity greater than 320, and D. Negative urine ketones.
NCLEX style question number 2. The first priority in treating acute HHS patients is A. Preventing infection, B. Restoring blood glucose levels to normal levels, C. Replacing fluid volume, or D. Assessing patient self-image. The answer is C. Replacing fluid volume.
NCLEX style question number 3. Which of the following fluids should be used to restore fluids in a hemodynamically stable patient with HHS? Is it A, 0.45% normal saline, B, 0.9% normal saline, C, dextrose 5% and 0.45% normal saline, or D, lactated ringers?
And then these are our references. Thank you.
Thank you.